Welcome to This Week in Anesthesiology. This week, we're covering 10 notable papers spanning perioperative pharmacology and medication safety, obstetric and pain medicine associations, and systems-level quality improvement. Let's dive in. Let's begin with perioperative pharmacology, specifically focusing on the safety profile of intraoperative methadone and the clinical implementation of newer agents like ciprofol. Methadone has gained significant traction in perioperative care due to its unique pharmacokinetics and NMDA receptor antagonist properties, which make it an excellent choice for multimodal analgesia. However, concerns regarding its potential to prolong the cardiac QTc interval and trigger dangerous arrhythmias have lingered, largely because of data from patients receiving high chronic doses for opioid use disorder or chronic pain. To address this concern in the surgical population, Ramaya and Karash conducted a prospective observational cohort study. They evaluated adult patients undergoing elective surgery under general anesthesia who received either a single intravenous dose of methadone at induction or a standard alternative, typically fentanyl, at the discretion of the anesthesia provider. The researchers monitored the rate-corrected QTc interval, calculated using Friedrich's formula, before and for 1 hour after opioid administration. The study included 547 patients with a median age of 59 years. Among them, 282 patients received a median methadone dose of 20 milligrams, while 265 received no methadone, instead receiving a median fentanyl dose of 250 micrograms. Remarkably, the primary outcome of new-onset rate-corrected QTc prolongation exceeding 500 milliseconds occurred in only 2.5% of the methadone group, compared to 8.3% of the no-methadone group. This translated to a relative risk of 0.34, representing a statistically significant reduction. Furthermore, secondary outcomes mirrored this finding. Any QTc interval exceeding 500 milliseconds, a delta QTc increase of more than 60 milliseconds, and the exceeding of sex-specific thresholds were all significantly less frequent in the methadone cohort. There was also no correlation found between the administered dose of methadone and the post-induction QTc interval or the change in QTc. These findings provide strong, reassuring evidence that a single intraoperative induction dose of methadone does not clinically prolong the QTc interval and is, in fact, associated with a lower rate of QTc prolongation compared to standard intraoperative opioid regimens. Transitioning to novel sedative agents, ciprofol is an emerging anesthetic that requires precise dosing guidelines, particularly in pediatric populations. Writing in the British Journal of Anesthesia, Liu and colleagues presented a population pharmacokinetic and pharmacodynamic analysis aimed at optimizing ciprofol dosing for pediatric anesthesia. The study enrolled 88 pediatric patients, ranging in age from approximately 1 month to 15 years, with weights spanning 4.2 to 71 kilograms, all undergoing cardiac or thoracic surgery. Anesthesia was induced with ciprofol at doses of either 0.6 or 0.9 milligrams per kilogram, and blood samples were collected using opportunistic sampling to characterize the drug's concentration profile. The researchers developed a 2-compartment pharmacokinetic model that incorporated body weight and an empirical maturation process as key covariates. To assess pharmacodynamics, they modeled the relationship between bispectral index and drug concentration using an effect compartment model, specifically in children younger than 3 years. Based on their simulations, the authors recommend a ciprofol induction dose of 0.6 milligrams per kilogram. For maintenance of anesthesia targeting a bispectral index range of 40 to 60, they suggest a weight-stratified infusion regimen, 1.4 milligrams per kilogram per hour for patients weighing 5 kilograms or less, 1.2 milligrams per kilogram per hour for those weighing between 5 and 30 kilograms, and 1.0 milligram per kilogram per hour for patients weighing more than 30 kilograms. They emphasize that any escalation above these maintenance doses should only occur under continuous bispectral index monitoring to avoid oversedation. Crucially, the authors caution that their recommendations for children aged 3 years and older assume a similar pharmacodynamic response to younger children, and potential inaccuracies in this older cohort warrant careful clinical monitoring. This focus on pharmacological precision and patient safety is highly aligned with broader national and international initiatives. In Anesthesia and Analgesia, Samos Williams and colleagues published consensus recommendations from the 2024 Anesthesia Patient Safety Foundation Stolting Conference, which focused on advancing perioperative medication safety through systems-based solutions, technological integration, and standardized labeling. Meanwhile, highlighting the real-world challenges of clinical standardization, a national survey by Burton and colleagues in the journal Anesthesia revealed significant variation in the perioperative management of GLP-1 receptor agonists among United Kingdom anesthetists. This variation underscores the urgent need for clear, evidence-based guidelines, as these medications become increasingly common in the surgical population, especially regarding preoperative fasting intervals and gastric ultrasound assessment. Our second theme explores clinical associations and recovery dynamics in obstetric anesthesia, chronic pain, and neuromuscular monitoring. In the obstetric suite, maternal fever during labor analgesia is a frequent clinical dilemma. It can stem from infectious chorioamnionitis or non-infectious epidural-related maternal fever, often abbreviated as ERMF. Because occult intrauterine infections are difficult to rule out, previous studies evaluating the impact of isolated epidural-related fever on neonates have yielded conflicting results. To isolate the true effect of ERMF, Yamazaki and colleagues conducted a retrospective case control study at a single center. They reviewed singleton-term deliveries under labor analgesia between 2017 and 2023, performing placental pathological examinations on any patient meeting risk-based criteria to strictly exclude confirmed histological chorioamnionitis. After propensity score matching, they compared 186 febrile mothers with 186 non-febrile controls. The febrile group experienced significantly longer durations from rupture of membranes to delivery, a longer first stage of labor, and a longer overall duration of labor analgesia. Additionally, maternal fever was associated with a substantially higher incidence of fetal tachycardia, occurring in 36% of the fever group, compared to only 10.7% of the control group. However, despite these intrapartum challenges, maternal fever was not associated with any adverse short-term neonatal outcomes, including umbilical artery pH below 7.2, low APGAR scores at 1 or 5 minutes, or neonatal intensive care unit admission. Long-term developmental milestones assessed via standardized parent questionnaires were also completely within the normal range for both groups. This study provides vital reassurance that when histological chorioamnionitis is excluded, epidural-related maternal fever does not adversely affect neonatal well-being or infant development, despite its association with prolonged labor and fetal tachycardia. In the field of pain medicine, a major epidemiologic association has been uncovered between Ehlers-Danlos syndrome, a genetic connective tissue disorder, and complex regional pain syndrome, or CRPS, in a retrospective cohort study. Wren and colleagues utilized the Meritive MarketScan database to analyze claims data from over 54 million commercially insured patients in the United States. Among this massive cohort, 26,053 patients had a diagnosis of Ehlers-Danlos syndrome, and 51,424 had a diagnosis of CRPS. The researchers identified a powerful association. The proportion of recorded CRPS diagnoses was 1.05% among patients with Ehlers-Danlos syndrome, compared to just 0.09% among those without the syndrome. This represents an approximately 11-fold higher proportion of CRPS diagnoses in the Ehlers-Danlos population. Among the patients with both conditions, the vast majority were female, with a median age of 27 years, and most presented with type 1 CRPS affecting the lower limbs. These findings suggest a strong population-level link, signaling that clinicians should carefully screen patients with connective tissue hypermobility for early signs of neuropathic and regional pain syndromes to implement timely multidisciplinary interventions. Ensuring complete physiologic recovery is equally critical in the immediate postoperative phase, particularly regarding neuromuscular blockade. A proof-of-concept case series by Wakabayashi and colleagues in Anesthesia and Analgesia investigated diaphragmatic recovery using dynamic digital radiography, a novel real-time imaging modality. The authors evaluated diaphragmatic mechanics in patients who had achieved a conventional train-to-4 ratio of 0.90 to less than 0.95, which is traditionally considered the threshold for safe extubation. Surprisingly, the real-time radiographic imaging revealed incomplete recovery of diaphragmatic excursion and mechanics in several patients within this range. This visual evidence challenges the assumption that a train of 4 ratio above 0.90 guarantees complete respiratory muscle recovery, suggesting that a higher threshold or more comprehensive clinical assessment may be necessary to prevent postoperative pulmonary complications. Our final theme addresses the broader systems-level challenges of our specialty, ranging from safety and non-operating room anesthesia to the management of major thoracic trauma and the environmental sustainability of intensive care. Non-operating room anesthesia, or NORA, has expanded rapidly, but these remote locations often present unique environmental, equipment, and communication challenges. To better characterize these risks, Piersa and colleagues conducted a qualitative, retrospective cohort study of quality assurance events across a large academic health system. Out of nearly 500,000 cases performed over a 4-year period, over 106,000 were performed in NORA locations. The researchers analyzed 984 quality assurance reports containing detailed clinician comments, coding them using both inductive methods and the Deductive Systems Engineering Initiative for Patient Safety Framework. The analysis revealed that NORA safety events are highly complex and rarely attributable to a single clinician error. Instead, they frequently involve systemic issues such as poor teamwork, communication failures across different departments, highly variable access to specialized equipment, and frequent equipment malfunctions. The study emphasizes that improving NORA safety requires institutional systems-level interventions, such as standardized equipment layouts and dedicated communication protocols, rather than simply relying on individual vigilance. In the acute care setting, the management of major thoracic trauma remains a major driver of mortality and secondary systemic complications. In a comprehensive narrative review in the journal Anesthesia, Kaur and colleagues synthesized contemporary evidence on diagnosing and managing major thoracic injuries. The authors highlight that even seemingly minor blunt chest trauma can lead to severe secondary insults, including acute respiratory distress syndrome, acute kidney injury, infection, and shock. This risk is particularly pronounced in older patients, who are often overlooked as a high-risk group and should have a much lower threshold for admission to specialized trauma or critical care services. The review underscores that while surgical stabilization of chest wall or diaphragmatic injuries is sometimes necessary, the cornerstone of management is aggressive supportive care. This includes lung protective ventilation strategies, early airway control, and optimal regional pain management to facilitate aggressive physiotherapy and prevent respiratory failure. Finally, our responsibility extends beyond individual patient care to global environmental health. The European Society of Anesthesiology and Intensive Care has published its 2026 consensus document on mitigation strategies in intensive care medicine in the European Journal of Anesthesiology. Recognizing that intensive care units are highly resource-intensive, with massive energy demands, high waste production, and extensive pharmaceutical use, a panel of 37 experts from 20 countries developed 37 practical recommendations. Using a 2-step Delphi process, the panel achieved over 80% consensus on all recommendations, with 32 receiving over 90% approval. The finalized strategies call for a complete transition to renewable energy in hospitals, the optimization of procurement and waste management to minimize single-use plastics, a reduction in the use of highly polluting fluorinated medications, and the implementation of ethically guided environmental policies. This consensus document provides a clear roadmap for departments to align their clinical practices with planetary health goals. If you only have time for one paper this week, make it the prospective cohort study on single-dose intraoperative methadone and the QTC interval by Ramaya and Karash in the British Journal of Anesthesia. This study provides high-quality, clinically reassuring evidence that addresses a major barrier to the wider adoption of intraoperative methadone. By demonstrating that a single induction dose does not cause clinically significant QTC prolongation compared to standard opioid regimens, it empowers clinicians to confidently incorporate methadone into their perioperative, multimodal analgesia protocols for major surgery. Here are the key takeaways from this week in anesthesiology. First, a single intravenous dose of methadone at induction does not prolong the QTC interval, or increase the risk of dangerous arrhythmias compared to standard opioid regimens, supporting its safety in perioperative multimodal pain management. Second, after strictly excluding histological chorioamnionitis, epidural-related maternal fever is associated with longer labor and fetal tachycardia, but does not result in adverse short-term neonatal outcomes or long-term infant developmental delays. Third, patients with Ehlers-Danlos syndrome have an 11-fold higher proportion of complex regional pain syndrome diagnoses, suggesting that clinicians should maintain a high index of suspicion and initiate early, targeted pain interventions in this patient population. Fourth, pediatric ciprofol dosing should target an induction dose of 0.6 milligrams per kilogram, followed by weight-stratified maintenance infusions, with continuous bispectral index monitoring recommended in children over 3 years of age to avoid oversedation. And finally, safety events in non-operating room anesthesia are predominantly driven by systems-level failures, such as communication gaps and equipment variability, highlighting the need for institutional standardization and dedicated protocols in remote anesthetizing locations. That's your roundup for this week in anesthesiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.